Learn the neuroscience of pain to get better clinical outcomes. Stay tuned because today you will discover mechanisms of threat detection and pain perception and techniques for integrating percussive therapy and NLP into clinical practice to effectively manage chronic musculoskeletal and somatic pain. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain based solutions so you can get better neuroplastic results with your patients. I'm honored to welcome our next guest expert. Dr. Tatiana Habanova is a chiropractic neurologist with a unique background in clinical neuroscience and functional medicine. Her passion for brain based healthcare and personalized medicine has led her to focus on helping high achieving women enhance their quality of life by enjoying an active, pain free lifestyle, optimizing their health, and thriving through menopause and becoming cognitively unstoppable. Today, she'll be sharing with us innovative approaches to chronic pain, the power of percussive therapy, and NLP. Dr. Hapanova, thank you so much for joining us as a speaker on the Virtual Neurology Summit. Please
Oh,
take it away.
thank you so much, Dr. Burns. I appreciate being here. So today I'm going to be speaking about the innovative approaches of chronic pain and the use of percussive therapy in NLP. Now, I know many clinicians are probably using a percussive therapy device in practice. It's probably found its way into almost every manual therapist's office since it's come onto the market in the last couple decades. But today I want to really share a unique way of actually utilizing that device and some eye-opening effects with that. So just to introduce myself once again, as Dr. Burns has done a magnificent job, I am the owner of the Palm Beach Brain Center, and it is a brain-based clinic. I do specialize in women's healthcare and brain-based health, but I also do work with a lot of athletes, especially equestrian athletes here situated in Wellington, Florida. So I do see a lot of pain-based patients as well as ones that have had endured injuries and have some chronic pain situations. So I'm very excited about sharing today. We're just going to briefly go over the neuroscience of pain, a little bit of some challenges in the pain management field. We'll talk about the new approach of using a percussive therapy device in a very unique way and layering in NLP. And I'm going to share, the clinical applications on how to do this. So you can start to do that first thing Monday morning in the office and have your first success case. And then we'll also go over a couple of case studies just for some examples. So I wanted to start today with just remind ourselves, if we haven't recently taken a look at the definition that the International Association of Study of Pain has provided us back in 1979. This has actually recently been updated, but originally it's interesting to note the vocabulary that they're using to define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such terms. So what's interesting about that is that recently in 2020, they've actually decided to just remove that last sentence, and they don't feel that the use of someone describing their pain has any association to that experience, that it's just really a sensory and emotional experience with a possible connection to actual tissue damage or potential. And I think that's a very interesting element of the potential tissue damage, where that's an imagined or, possibly there's a concern that there may be actual damage occurring and how some of these pain pathways start to occur. So I just highlight a couple of the important terms there just to see what our current definition here as it stands of 2020 that the IASP has. So it's also gone on, their task force has defined chronic primary musculoskeletal pain, obviously in the bones, the muscles, the joints, the tendons, the musculoskeletal system, but interesting enough, characterized by significant emotional distress. So very interesting use of words, as well as a functional disability as opposed to a structural disability. So again, I think some of these the definitions and the key words that are being used is important to hone in on. Now, I know many people may not be familiar with neuro-linguistic programming, also known as NLP. This was developed by Dr. Richard Bandler and John Grinder in 1975, and their definition of what NLP is a connection between neurological processes, language, and acquired patterns of behavior. And they believe that these could be changed to achieve a specific goal. So I just want to layer in some of these definitions as we begin the presentation, just to kind of help open the mind and keep all those ideas present. So just a couple quick things as we look into the field of chronic pain. Here in 2011, they did a study as now showing globally that each year at least 10% of the adult population is newly diagnosed with pain, and on average about 20% of the adult population suffer with pain, and that's globally. Interesting to know that here in the United States, our prevalence is a little higher, to 12 to 25% of our population is suffering with chronic pain. And they went on in this article just to identify the four largest causes of pain. Number one being cancer, the pain of cancer. And then the other three, osteoarthritis or rheumatoid arthritis, injuries, operations, and spinal problems. So I think for a lot of manual practitioners, people who are listening to this summit can relate to those areas because you're probably most likely treating them. You're seeing them in your patient population. Interesting as well is that the amount of time that someone is generally living in a state of chronic pain tends to be on an average about 7 years. So that goes to say that there probably isn't really great ways of trying to diagnose, identify, or treat people, and that they're having to live through this. And this really has a lot of issues. Obviously, it's uncomfortable, it's painful, it's not pleasant to be in that level of chronic pain, but leads to depression, inability to work. Obviously, it disrupts social relations in terms of just being mobile, being able to go out and do things, and also can lead to suicidal thoughts. So this is a really important area. It's really becoming kind of a global sort of epidemic in that sense, and the mismanagement or inadequately managed musculoskeletal pain really has an adverse effect on one's quality of life and a lot of impact on social economical status in that regard. So interesting enough as well is that chronic pain actually costs much more than any of the other six major diagnosed conditions as reported by the NIH. So, for example, cardiovascular disease, neoplasms, endocrine, metabolic, digestive, respiratory, don't even touch that. The amount that chronic pain is impacting at least about 1 million adults and costing somewhere between 560 to 635 billion dollars a year. So it's a pretty big industry and pretty important that we find some new ways that we can address this pain. So the sad truth is, 1 million people across the globe, excruciating pain, unfortunately, is an inescapable reality of life. So just to kind of briefly go over a little bit of neuroscience of pain, of course, this could be a whole seminar and summit in itself, but just a couple of key points I thought was interesting was that this theory of pain initially was actually developed by Rene Descartes back in 1664. So our initial understandings as how Rene, theorized, it's really just a theory of what's kind of happening is kind of what we, kind of we're familiar with previously, where just pain is like a bell ringing system. It's just sterile purpose is really just to signal injury to the body. And it's funny that in an attempt to placate the church, he needed to include within his pain theory that there was some connection to the soul. So due to his research, he says that the soul of pain was actually located in the pineal gland. So somehow, bringing the brain into it as a moderator of painful situations. And this theory has been prevalent from 1664, so very outdated as we know today, but until 1965. So 301 years later, finally in 1965, there was this wonderful publication by Malzek and Walls, Pain Mechanisms, A New Theory, published in Science. And basically they proposed the gate control theory of pain, which is of course what has become widely accepted today, where we know that it's again a theory, it's just a theory that proposes that in the dorsal horn of the spinal cord is a gate that will modulate the flow of nerve impulses from the peripheral fibers to the central nervous system. And this gate is influenced by a variety of things, from peripheral nerve activity, as well as descending influences from the brain. So It's rather interesting also just to note that they have recently passed and that their work has really been transformative. That here now we have a whole industry of pain science and pain research, and so that their theory, really provide a framework to help better understand the complexity behind chronic pain. So we want to thank him for that as well. Dr. Malzek also created the McGill Pain Questionnaire, which has become very influential in helping to understand how to quantify pain. Interesting, though, that they still had to, in 1982, defend their gate control theory of pain that they proposed in 1965. Now, that's the article listed there. That, again, had initial resistance, but now has been widely accepted. And Dr. Malzweck is also quoted as saying that, this new concepts, provide that foundation and framework for a host of novel, exciting approaches for the treatment of pain. And that was really his wish, that when they presented that material, that would be able to alleviate the suffering. It was also started to show that this, chronic severe pain is seen as a disease in itself, as opposed to just a symptom of a disease or a symptom of injury. Sort of as Descartes has said before, it's just a signal to indicate that there's something going on in the body. But now Malzek and Walls have really provide that framework to say, no, there might be something going on that is causing this chronicity to occur. All right, so real quick, just to refresh our memory, we won't go through this in great detail, but just to remind ourselves that all the receptors that are occurring cutaneously, from our free nerve endings here in the red, where, we have our myelinated A delta fibers and the unmyelinated C pain fibers, which obviously are, important in terms of delivering that nociceptive input. But we also have a variety of other types of receptors that we don't want to forget about and that we're going to be utilizing within this technique. As well as we have our mechanoreceptors, our wonderful muscle spindles, and our GTO, glutein organs. So again, our 1A and 2 and 1B afferent fibers. Again, just to refresh and just bring this up to memory, is we want to remind ourselves again that our A beta fibers are the ones that are going to be those large myelinated fibers, and our A delta and C fibers are a bit slower, and of course they will transmit different types of pain as well. So I'm sure this brings back many memories. So, of course, the gate control theory of pain, which many people are now familiar with, is this idea is that those larger beta myelinated fibers are able to, are faster, are able to kind of get through the gate, and then the gate kind of closes and doesn't allow the C fibers to go through. Unless there's an inhibitory interneuron that's maybe not functioning as well or not providing some modulation, then there can be transmission of those C fibers, i.e. pain, that can be projected onto the brain. And an interesting note here too is to recognize that there's a lot of work that Walls particularly was interested in is looking at a decrease in inhibition or an increase in excitability of the nervous system as a potential source of chronic pain. So really looking at what's happening here at this interneuron and perhaps other synaptic connections that are occurring. So for example, we can see that there is quite a number of top-down mechanisms coming from the frontal lobe, where we have cognition, and the limbic system, where we have emotional processing, coming down into the midbrain. Okay, so down here into the brainstem, into the periaqueductal gray area, and then synapsing and sending a variety of inhibitory neurotransmitters to help modulate what's happening at the dorsal horn. So we have our receptor, we have the nociceptive information, and then we have some modulation as we might try to alter what's going on in our second order neuron into the thalamus, and then back up into the third order into our parietal lobe. So I know this isn't a great clear screen here in this picture, so I'm sorry about that. But I really like this picture, and just, squint a little bit, maybe it'll become a little clearer. But the idea of this unmyelinated C fibers projecting into that dorsal horn, remember we have the lex lamina numbered. So, and our myelinated A fibers as well, going to different areas. And again, once again, seeing those descending inhibitory neurotransmitters being able to act on those areas. So a lot of modulation happening, as well as when we have the ascending pathways moving up to the brain, there are also other things that might be even enhancing. So going back to that comment that Walls was really pushing towards the later years of his career, that there's something going on with the inhibitory or the excitatory elements that are influencing the nervous system. So I think he was really onto something. Just a little clearer visual on that there, so you can see where the A beta and then the delta and the C fibers, the pain fibers. We also want to remember that there can be a neurogenic sense of pain where there may be things going on, for example, with substance P. We may have some other influences at the dorsal root ganglia. So there might be other things that are causing an excitation to occur and possibly causing a condition of central sensitization where, for whatever reason at this point, pain pathways or pain experiences are being propagated here within the dorsal horn. So I just really want to refresh your mind of just some of the potential mechanisms that can occur. Let's compare these two diagrams on the left and right. So as we have transduction, so we have the neurotransmitter, the receptor is going to transduce its signal into an electrical signal. It'll travel up into our first order neuron. We'll have our synapse. Of course, if it's the anterior lateral system, we're going to be transmitting pain all the way up into the thalamus. But we need to remember that, again, there's projections into other areas of reticular formation in the brainstem, up into the limbic system, and of course, our somatosensory cortex in the parietal lobe for conscious experience of that. And once again, remembering we have top-down mechanisms. So definitely chronic pain is a complex pathway. Lastly, we also want to just remember that there are the other ascending pathways that we want to just keep in mind. So obviously our dorsal columns are really important, are going to be transmitting a lot of the pain and vibration, which in the percussive therapy approach, we're going to be utilizing, as well as we have our spinal cerebellar pathways, again, very important in delivering proprioceptive information, particularly in the lower limb, as well as we have things as like our spinal tectile, spinal reticular pathways, again, very important in conscious awareness, alertness that's evolved with our sleep wake transitions as well. Spinal olivary pathways, very important too, to again help us understand our cutaneous and perceptive sensations that are around control of body movements. And lastly, our spinal vestibular system, very, very important in terms of just head-eye coordination, posture, balance, spatial orientation and motion. So a lot of other ascending pathways are being involved in transmission, and we want to keep that all in mind. One thing I thought that was really important as I prepared for this presentation is came across this really nice paper, Chronic Pain, the Role of Learning in Brain Plasticity. And I just can't help coming off of, some of the work that Malzig and Walls have done. I encourage you to read their original work. It's very eye-opening, and they're very much onto something. Is that chronic pain is the persistence of perhaps a memory of pain. So I really like this diagram showing that, the nociceptive information is, being transmitted to a variety of areas, not just that simplified diagram that we tend to learn in school where it goes to a little sliver of the parietal lobe, and that's it. No, there's many areas. And then how do all those feedback? So looking at our lateral prefrontal cortex or medial prefrontal cortex, taking a look at what's happening here in the area of perception. So our anterior cingulate cortex, right? The limbic system, really important in reward and punishment in relation to behavior. This is also emotional expression and awareness. Also involved in cognition in terms of decision making and processing of those rewards. And interesting enough, it's also important in evaluating sort of that cost benefit. As information comes up, it's sort of weighing out those cost benefits. So again, as we're, potentially maybe having nociceptive information being conveyed up to the brain, that anterior cingulate is evaluating some of that information and influencing motivation and behavior. So something to consider. It is also involved in pain management, autonomic responses. So really a lot going on. The insula I thought was really, really interesting that this paper brought that up because they really heavily spoke about the insula. We know interoception, it's involved with just sensing what's going on internally. There are a lot of multimodal sensory processing that goes on in the insula, as well as autonomic control, which is great, perception of self-awareness, memory, etc., emotional guidance, social behavior regulation. But the paper really discussed on valence processing. And I found that quite interesting because valence processing is the ability to the degree of determining which is something's pleasurable or something's aversive. So does it have a positive valence or a negative valence? And the insula is very much involved in that. So it makes sense that would be involved within pain mechanisms. And this idea that potentially pain is just this chronic state of continuous learning and the inability to extinguish a memory from the past that was initially provoked. So I think just all of this is important as we just keep in mind, oops, excuse me, we did that slide, as we move forward and consider some new possibilities. Real quick, just 2 seconds, just looking at some of the latest data, 2021 in this paper, really talking about the 3 major challenges to our current pain management system. Really, they're the use of over-imaging. 69% of general practitioners refer patients out for radiographs, for x-rays, imagings at the first presentation of pain. Even though it's not routine. The routine use of x-rays and imaging is discouraged, especially with low back pain, although it's still being done. And the findings are just showing a poor relationship between what they're seeing and the symptoms. So again, overuse of imaging is not really helping us in this area. We know the overuse of opioids has been an issue for quite some time, and lots of changes have occurred on that front. And lastly, overuse of surgery, showing that surgeries are increasing. So just even the rate of knee surgery here has gone up by 1% in the US population. Perhaps that's because the population is aging and more people need that. So there might be some correlation there, but perhaps that's not always the reason for someone's pain and discomfort. So we really want to continue to evaluate structure and function. Is there something structurally causing that issue, or is there something functionally happening in the background in these pain pathway projections? All right, so let's go ahead and get to the nitty gritty and the important things. So let's talk about a little bit of some of this new approach to pain management. And there's a nice paper that came out in 2023. This area is new, very, very new. So there isn't a lot of research being done yet, but there was some. And so this paper was able to put together a systematic review, which is really nice, of what has currently been presented. So percussion therapy, or percussion as it's known, it was actually first developed in 1950 by Robert Fulford, actually for the use of deep tissue orthopedic treatments of osteopathic treatments of musculoskeletal pain. So pretty much how we're going to be using it today, it's already kind of been created back in the day. So interesting. Not much more information is known from there. We do know the first commercial use of these machine therapy devices was invented in 2008. So maybe, about 15-ish years or so, a couple decades. And their popularity has obviously grown, professionally as well personally. So the key here is just that, vibration, that rapid pulses of short bursts and pressures. These are some of the key things that we want to focus in on as we are trying to stimulate some of our A beta fibers. Now, in this paper, they were showing that percussion therapy definitely showed positive gains in muscle strength, explosive muscle strength. So that's interesting. The ability for more flexibility. It definitely discussed the experiences of pain. It talked about pain versus flexibility and the benefits that produced, as well as addressing the gate control theory of pain, as well as discussing the metabolic changes that are occurring due to the use of percussive therapy. As a side note, something that I have noticed in practice, so I've definitely seen all of this occur, absolutely. And also, I have seen some really nice benefits of really reducing cellulite and lipidemia. So, a lot of just really inflamed tissue. So, again, that could lead back to some of the metabolic changes that they may be discussing, or improving cellular health, or just improving the blood flow and circulation aspects of things. So the current application, again, I'm referring to the article, is talking about kind of floating the percussive therapy device over the skin. This is probably how most people are using it. I'm pretty much 99.999% sure that that's how everybody is more or less using it. We've never really been taught, at least I haven't come across anything professionally myself. Just these devices were made available, and the idea of kind of mowing the lawn or vacuuming with them is kind of, I think, how everyone has sort of done it, right? And it has, I'm sure, brought results, but they're limited. And so I'd like to introduce instead a different way of utilizing this device. And this was taught to me actually by a colleague. His name is Freddie Vega, and he is a fitness rehabilitation professional. He's a functional movement specialist. He is a licensed clinical hypnotherapist. And he's the one that really exposed me to this technique that I'm sharing today. And I'll teach you how to do so you can right away do it. But I just want to give him credit since he's the one that exposed me to this. I've been using this within my practice for the last year with great success, and it's becoming one of the most sought after treatments that I offer in my practice. So it's been very exciting to help people with a lot of their chronic pain issues, and to have such rapid results and long lasting as well. So I want to give him credit for producing this method, the Vega method, which is incorporating a particular use of percussive therapy device and layering in the NLP together. All right. So how do we do this? Well, first of all, as some of the other images were showing, it tends to show that, you're kind of getting a massage and you're disrobed. You definitely do not need to, it can be done with clothes on completely. Of course, if someone comes with a pair of shorts and you want to work on their lower limbs, you can do the hamstrings, let's say quads, calves, whatever the case is, you certainly can do directly on skin. I have all my patients, tend to be with long, exercise pants or something like that. So no need to be undressed at all, which is actually quite nice. Makes it very simple. You're going to select a particular speed that's tolerable. So again, I'm not, just a disclaimer, I have used many, many percussive therapy devices, probably everyone on the market I've explored and determined which I like and don't like, and which I think are better, not better. I'm not here to discuss that. I do have my preference. But the key here is to, when you're working with the patient, let's take the gentleman at the top where they're working across the traps there, let's say, or if you want to look at the IT band, quad area, that's totally fine. You're going to select a speed that is appropriate for the patient and a pressure. So a lot of times when patients have a lot of pain, you're actually going to hold the device a little bit off of them because the weight of the device itself may be a little too much, and the speeds. Interesting enough, sometimes a little faster is more comfortable, sometimes a little slower is more comfortable. You'll have to really play with it and ask. And you're going to basically, and this is where the difference lies, this is the key, it's very simple. You're going to hold the device over that particular surface of skin. Let's say it's the IT band, or the medial or the lateral border of the vastus lateralis to the IT band, or wherever it is. You're just going to hold it on the surface until the pain or unpleasant sensation diminishes. Now, many times it will go away that quick. You'll ask the patient, you're going to be asking constantly on a scale from 0 to 10, 0 being no pain, 10 being the most intense pain, what are you experiencing? And of course, you don't want to be having them in there, 8, 9s, and 10s. That's a little too much, right? So if it's that much, you've got way too much speed going on, or you're pushing too hard. Okay, you got to back off. So find that spot where it's tolerable, maybe a 5, 6, possibly a 7, and you're just going to leave it there and sometimes it could take up to 30 seconds or more for there to be a change. And they're starting to say, I think it's going away, maybe. Oh, yeah, no, I think it's gone away. It doesn't feel as bad. And then you'll move to another little area and they're like, oh, that's really intense again. And you'll keep asking and you'll just keep working through this. And you're basically going to map out an area. So again, let's say you're doing the traps, or let's say you do the quad, you're literally going to map out the whole tissue. Sometimes it vanishes just like that. You get there and they'll be like, oh, that's a 6. Oh, it's gone. It's literally sometimes that fast. Other times, if you're lingering on a spot more than 30 seconds, I recommend, again, there's no research or anything behind this, just clinical experience, is to just move off to the side slightly to another little spot, because maybe there's another area that needs to release first. And then you come back to this spot and it probably won't be as bad and it'll go away quicker than staying on too long. Because we do want to be mindful of not creating any local tissue, damage or injury or anything of that nature as well, right? That's not the idea behind this technique. So mapping the area is very, very key. And again, the results are immediate and they're long lasting. Of course, depending on one's chronicity, they may need more sessions. So that's something to consider and evaluate. But even people that have been in chronic pain for several years, even a small handful of sessions, less than 5 perhaps, they're transformed, and it's very, very interesting. So I encourage you to try it this way. You'll figure it out, but definitely hold it, then map it and map it. So yes, that these sessions may take a little bit longer if you're using this within your just some for soft tissue kind of massage. If 10 minutes in your treatment session, nah, you're not going to get much of a result. You're going to need to spend a little more time to really kind of eliminate that whole area. So just keep that into consideration. So once the area clears, if you like to work deeper, then what you can do is you can keep the same speed and you can increase a little pressure, because now they might be like, oh, that's painful again. You go, okay, and you'll leave it the same speed and that pressure, and just keep asking them, okay, is that under a 7, and tell me when it drops down to a 5 or a 4, it goes away. So you're constantly communicating with the patient about that. It's a very interactive experience. Or you can keep the same pressure, but you can increase or decrease speed. So again, you're just basically playing with the receptors and the types of information coming in, right? So playing with those two things. Now, something that's actually even more beneficial. So once you master the one percussive therapy device and you're kind of working with this new technique, the best is to apply 2. Is to work with 2 percussive therapy devices, okay? At first, it's a little uncomfortable. You've got 2 going and you got to kind of figure out how that's going to work. But honestly, it's a much more comfortable for the patients. You clear the spots faster. You just got to watch that you don't accidentally pinch tissue between the 2 knobs, okay? So careful with that. You can then start layering it in when you're going to be doing it during exercise, or maybe someone's in like a pure form of stretch and they're actively stretching and you're doing it through there. So you can get really creative with that. So let's talk just a little bit about NLP. I've layered the techniques here for you on the screen and the next, so you can see what they are. And again, just understanding what they are and them into your percussive therapy session. Certainly you can do the percussive therapy on its own, but definitely when you add the NLP aspect to it, you really get much greater results and much faster. The key here to NLP is really creating a lot of rapport. I'm sure if you're working with your patients, you already have done that. We naturally do matching and mirroring, where we match tones, language, posture. This is just what humans do when we want to create rapport connection and be on the same page with someone. So I think you're probably already doing that. But what you'll notice in some of these techniques, for example, like reframing, where you're changing one's mind map from something negative to something positive, you're really bringing in an aspect of imagery, right? So if someone's like going to say something like, you'll hear patients say, oh, I'm always in pain, it just never goes away. And getting them to reframe that by saying, well, I can be pain-free. I was once before, I can be again. And having them start to just change their own vocabulary and their own sentences that they're saying, having them start to rethink a little bit their situation. Again, you're probably doing this naturally already as a clinician, right? A switch technique, again, is just if they're visualizing, sometimes maybe you're going over an area, they're like, oh my God, that's when I fell when I was skiing or whatever. And then like an old memory comes to mind and they start to verbalize that. And you could do a swoosh technique where you just ask them to instantly, start considering something different in that moment. Like, what could they be doing instead? Like, if they couldn't be writing, have them imagine that. So again, imagery. Okay, another imagery. Dissociation, we're just trying to detach from that physical emotional experience. Once again, imagery, taking their mind away from currently what's going on to having them feel something wonderful. And because the progressive therapy is so fast, they go from feeling pain to immediately not. That really helps the dissociation aspect. So you can just encourage that with your communications with them, guiding, nurturing them in this neurosomatic transformation that you're occurring in the session. Belief changes, getting them to, one of my favorites is actually is I'll tell them they have two knobs, and then on they have a knob that they can dial up the pleasure, and they can dial down the pain. So as we're going through this, I want them to have the knobs, and it's interesting because you'll see as I'll watch my patients, and I'm mapping, let's say a hamstring or something, or a quad, whatever the case is, and you'll see them all of a sudden just start like dialing up the pleasure, dialing down the pain on their own after give them that instruction to do that. They're changing their belief that they have control. They can dial up the pleasure and dial down the pain. Again, imagery, right? Etc. So these are the techniques here. So not that you have to be an expert in this, but just knowing that it really layers. And there's going to be so much more research that's coming out here. I believe that how these techniques are working together to be as beneficial as I'm seeing in my practice is this idea of motor imagery. As we just saw with NLP, a lot of the techniques are having a person kind of reframe, reimagine, reassociate, create new beliefs, all visualizing. And so motor imagery, just the simple mental simulate of an action without actually engaging in that physical execution of that action, right? So we know visualization. We know Olympic athletes do this all the time. They're visualizing what's going on. And we know that prior to any movement, like even if we're going to just reach for a water glass, prior to the actual motion, our brain has already fired the 17 pathways needed to do that action prior to us doing that action, right? So we have that aspect already occurring. And if we imagine that movement or do the movement, studies have shown that the same areas of the brain light up. So by layering NLP, having those conversations with your patients, having them transform their own language and thoughts, beliefs, as you are creating a stretch or a deformation to the tissues and all the receptors involved, and that area is being lit up in the brain in terms of movement, right? Or if you're doing it while they're moving, definitely I think we're getting some layers of neuroplasticity occurring. So cortical connections are continuously being reorganized. We know that it's really important, and that's as a result of peripheral and central input. So basically, one's experience can modify brain structures and their function. So interesting enough, just one final thought here, we'll finish up, is that the areas that are lighting up, we can see here, are involving the speech area of Broca, as well as, of course, our motor cortex. And then we have our prefrontal cortex and some association areas. So I just find the whole field rather fascinating. So once again, our definition here of sensory and emotional experiences, this association of actual possible potential tissue damage, I think is a very good definition. And we really play with the words. We can really work on a variety of things. And once again, is chronic pain this role of learning and brain plasticity? If it is, we know we can influence that plasticity as positive plasticity, and perhaps change maybe some of that negative plasticity that might have occurred to cause a disrupt and cause a disease of chronic pain as opposed to a symptom of pain. So let's talk about some couple case studies real quick here. A 52-year-old woman, chronic pain for 10 years, worst pain she's ever had in her whole entire life. She kept 10 out of 10. Did the whole sort of holistic approach initially, never, no results, kind of had to resort to injections, still no improvements. Ended up having a meniscal surgery. The MRI did show a tear in the meniscus, so the surgeon felt that would be the trick to take care of it. Had physical therapy after surgery, regained the recovery of the surgery, etc. Still no improvement in the pain or her functionality. Couldn't get out of a chair, limited in walking, couldn't go upstairs, really is becoming really immobile, etc. Unable to sleep. Sleep is really the biggest issue. Just laying down flat, sleeping, no relief at all. Work was significantly being affected, ended up gaining about 60 pounds. Really the mental state got affected. You can understand how her life is basically deteriorating in these last couple of years. So interesting enough, one session, and at that time only was able to really do the quad and the calf on that side. So initially when people do come in with a lot of chronic pain, mapping through the areas and really making sure that that tissue no longer experiences any discomfort before moving on to the next part of the, let's say, quad, right? It's really important to clear. It can take a little time, but after that 1 hour, she was able to immediately improve walking and definitely felt a change in pain, which said it was about a 7 out of 10, and it stayed. She wasn't able to come in very frequently. She had about 3 more sessions over about a 3-month period. That's generally not how we do it, but that's how this occurred here. So in that sense, she ended up becoming pain-free. Perhaps the sessions she was having, and then that she was being able to walk a little bit better with less pain, and just able to live life a little bit better each time, start to really kind of almost be her own therapy in that sense. And then she was able to return back to work full time and to physical activity. And that person was me. So I ended up, having a significant knee pain. You know the story. Here's some pictures of a trip that I just got back from yesterday, actually, with my mother. 3 weeks in Europe, where we're here in Mykonos, the Acropolis in Athens. This is in Florence, the Doma. Malta, the bell tower, of course, Santorini, very important. And this is in Olympus, this is the original Olympic grounds, the tunnel that the athletes would run through. The roof is now gone, but that would be the original tunnel. And I know you really can't see it, but way back there was actually the arena. So, and plus some more cities. We did 6 countries, 14 cities. Since I've had those percussive therapy sessions and NLP technique with the colleague I've explained, Freddie, treated me in that duration, and have now lost 30 pounds, was able to walk 15 to 20,000 steps per day all through Europe, up and down, etc. And so I am a believer. Another example of another male physician here, 63-year-old male. He had spinal surgery, ended up being pain-free for 2 years due to that, but then developed some SI discomfort. He himself was unable to walk as well, very debilitating. Sought the traditional treatments, the same kind of story. Didn't really have much improvement on that front. Ended up having weekly treatments for about 3 months. And what that looked like was a combination initially of passive care, so just the percussive therapy with the NLP. As he started to improve, we started combining some of the passive care, a session of just doing percussive therapy, and then starting to add in some active care, which consisted of some functional movement training, and then eventually a little bit more functional movement training, a little less percussive therapy, et cetera, et cetera, et cetera. Now he's playing pickleball 3 days a week and golfing 3 days a week. Now there's lots of different ways of treating SI pain, but he even says he feels much better than he even had before this, when he was much younger in the spinal surgery and ever. Like, it's completely just transformed his ability and life. So I'm very excited about that. So just in conclusion, just how do I do this in practice is something you might want to consider implementing. Here's a few ways. So body-based treatments, when people are coming in to see me for chiropractic care, I will do about 15 minutes of a spot treatment of the percussive therapy within their session. We also have Pilates rehabilitative sessions in the office where people are coming in and doing Pilates, but then we'll take time and do a spot treatment if we need to in that regard. Also within brain-based treatments. So when I am working with concussion patients or people who are looking to improve their cognitive performance, we will actually do percussive therapy as a full head to toe session, and or we will also use a whole body biplate. So it just sort of depends on what they need, and it's very case specific, but that's also very useful. The whole body biplate is, looking at us slightly from a different perspective. That's not going to really treat chronic pain in the way that the progressive therapy session will. But again, interesting to note that. And then we see a lot better improvement in their neuro performance. And then it's actually what's been very successful is a standalone service. It's an hour long. Definitely people who are coming in for pain. Others are looking for improved performance. And as I said before, maybe aesthetic in the cellulite, but it is very interesting to see how much of the lipidemia and the cellulite has completely transformed, metabolic changes, etc. So we do an hour in the beginning. It can take some time to map it all, but as people improve, it gets a lot faster. And eventually we can do the whole body within the hour as well. All right, some references for you and any contact information if you need to reach me. So thank you.
Dr. Habanova, thank you so much for sharing such a useful and practical tool with all of us today. We really appreciate you. I'm going to go through a summary and then a couple of questions for you. So, you talked about at the beginning what pain really is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And we know that chronic pain also is characterized by emotional stress. And so, you talked to us about NLP being a connection between neurological processes, language, and acquired behavioral patterns that could be changed to achieve a goal. And then looking at some of our stats regarding pain, so about 20% of adults have chronic pain globally, and in the United States, up to about 25%. Main causes are things like cancer, osteoarthritis, injuries and operations, and then spinal problems. 7 years on average having chronic pain. So this is something that lasts for a significant amount of time for each patient. And then depression, it can be associated with impacting social and ability to work, and can even lead to suicidal thoughts. So this is a very significant impact. We've seen inadequate management, how that could be a very significant burden on the patient and as well as economically. And then tracing back our origins regarding pain, 1664, Rene Descartes, that pain is a bell ringing system, connection to the soul via the pineal gland. And then fast forward to 1965, Melzack and Walls, the gate control theory of pain, where the dorsal horn gate modulates the flow of nerve impulses from the peripheral nerves to the CNS. And chronic pain is a disease, not just a symptom. And then, so looking at the skin receptors, we have pain, touch, temperature, light touch, pressure, vibration, deep pressure, and stretch receptors. And our mechanoreceptors, including our muscle spindles and Golgi tendon organs. A beta large myelinated are faster, able to get through the gate, whereas A delta and C are going to be slower fibers. So C fibers transmitted when there's a dysfunction of the inhibitory interneuron and decrease in inhibition, or it could be an increase in excitability. And so cognitive and emotional processes, we also have descending pain inhibition. And our pain pathways, so C fibers in the spinal cord to the spinal cord, and then descending inhibition neurotransmitters to help modulate pain. And with neurogenic pain, we can have substance P at the dorsal root ganglion, and then patients may experience central sensitization where they're experiencing pain at a lower threshold. And then transduction, so receptor transduces signal to the first order neuron, the anterolateral system, and then thalamus, and then reticular formation / limbic system, so also the limbic system, and then perception of the parietal lobe. With ascending pathways, we have many other ascending pathways: dorsal column, spinal cerebellar, spinal reticular, spinal vestibular, to name a few. And then the role of learning and brain plasticity. So chronic pain is a memory of the brain. Chronic pain is a state of continuous learning. So not only are we, stimulating the parietal cortex, but also the anterior cingulate cortex, the limbic system, the insula, autonomic responses, and then valence processing in the insula, the degree of pleasure or discomfort. And then challenges in pain management. So overuse of imaging, poor relationship between imaging and pain, opioid use, and then surgery overuse. So we always want to evaluate structure and function. And you share with us really excellent information regarding the percussive therapy and a great application, most importantly. So applying vibration and rapid pulses in short bursts of pressure to the muscle belly or tendon, type 1A muscle spindles, type 1B GTOs, as well as the A betas. And then in terms of gain, so muscle strength, explosive muscle strength, flexibility, experience of pain changes, and then metabolic changes. And with application, I think you nailed it. Most of us, myself included, we just kind of float the device over the skin, kind of in, whatever pattern feels right at the moment, leading to limited results. And so now a new application that you shared with us is it can be done clothed, select a tolerable speed and pressure, changes as the area improves, and then hold the device over the surface of the skin until pain scale vanishes completely. If it doesn't decrease within 30 seconds, move to adjacent areas and clear that area, then return to the first area, and then map the whole area. So getting immediate results, long lasting, of course, based on chronicity for the patient. And then you can also apply two devices simultaneously. And then combining that with NLP, which is absolutely brilliant. So with the percussive therapy, and with NLP, doing things like mirroring and having a rapport with your patient, anchoring, reframing, changing the mind map from negative to positive, using switch patterns to consider something different in the moment, dissociation, belief change. So I love the dials, dialing up pleasure while dialing down pain. What a wonderful thing to be focusing on. Instead of the patient just thinking about all the things they need to do or how much the pain's impacting their life, how beautiful to dial up pleasure and dial down pain. And then affirmations and the meta model. And so truly being able to change the perception and utilizing motor imagery and action observation. So it stimulates action through visualization, creates neuroplasticity, the prefrontal cortex and motor cortex. And then with body-based treatment, so about 15 minutes of spot treatment, combining with chiropractic and Pilates, and then remap the somatosensory cortex. You can also use whole body vibration for more remapping. And then you can also do standalone treatments for about an hour. Really wonderful. Thank you so much for this great application and for sharing with us. A couple questions for you. So this is a very specific technique versus just the more generalized, kind of putting it around the area. So if patients have percussive devices at home, do you recommend that they actually don't utilize it at home because it's not as specific, or do you recommend that they still use it at home in between visits? What's your thoughts there?
That's a really great question, and patients ask about that because they kind of see how simple it is to kind of perform the technique. Although there is a lot that goes behind it from a clinician's perspective. But yes, I actually teach my patients how to do this at home. I do recommend a particular device that I particularly like. It's not very expensive. It's about $100 on Amazon. So I'll just show them the link. They could buy it themselves because some of them have some different devices and the speeds and etc. There's a lot on the market. And I show them how to do that. I'll teach them how to do that. If it's areas they can't get to, like on their back or whatever the case, I'll have their spouse come in and I'll have the spouse, learn how to do that. It's usually best for the spouse to have their own treatment for about an hour so they can really experience it, so they could deliver. Yeah, it's definitely for sure. And I know patients do like it. It's just not the same. So they will do it. And I encourage them to do it in between sessions, but it's so different when it is done to you. It's much more powerful. So, but definitely they can and to be taught how to do it safely.
Wonderful. Thank you so much. And as we wrap up another great session today at the Virtual Neurology Summit, I'd like to acknowledge Dr. Habanova for her excellent work in functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host of the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.